Hi, good afternoon. My name is Rosalinda Velasquez, and this is my final project for my MSN in leadership. So I am doing a project on preventing CLABSIs in the ICU. My project details, it happened at HCA Healthcare Medical Center in Houston, Texas. I did the project in both CVICU and MICU. MICU had a total of 12 beds, and CVICU had a total of 22 beds. My project did start on October 1st, 2024. It is still in progress, and we've had some good results by November 20th. Some of the stakeholders involved were the CNO, the Vice President of Patient Safety, Infection Prevention Director, Education, the Vascular Access Team, ICU Nursing Leadership, and Clinical Nurse Coordinators, which are the charge nurses of the units. First, my needs assessment for the ICU consisted of monitoring the CLABSI rates quarter over quarter. And we did notice an increase in CLABSI rates from this year. We also saw an increase in utilization of central lines quarter after quarter as well. And these were mainly because of our high acuity patients that we have received within the past couple of months, as well as having new graduate nurses that really don't know when to de-escalate and escalate central lines and things like that. We were seeing inconsistent maintenance of central lines. Some of this was due to frequent changing of the dressing change schedule. And then we also went through a period where our dressing change kits were also being changed and upgraded. Um, and then we did have some nursing leadership changes in the ICU as well, which caused inaccurate and inconsistent audits by nursing leadership on central lines. This is a graph on our year-to-date CLABSI assessment. As you can see, our trend for our reportable CLABSIs in 2024, quarter one, we had 0. And then my needs assessment were for quarter 2 and quarter 3. We had 1 reportable one in quarter 2 and 3 in quarter 3. And then as of November 20th, we have had 0. We have had 0. And then as far as our utilization, our goal is to have 1 or less than 1, but national safety goal is 1. Our central line utilization for quarter 1 was 1.3, then 1.5, 1.4, and we have gone down to 1.3 as our lowest for utilization. My project consists of preventing CLABSIs in the ICU. How I did this is I made a CLABSI prevention work group with important stakeholders. I collaborated with ICU intensivists on our new initiative, and I reminded them of our old processes with blood culture collections and ordering, as well as audit tools for inserting central lines. I worked with education to increase our CLABSI metric education. I implemented audit tools for nursing leadership as well as the charge nurses and the vascular team. I made frequent reporting meetings to administration to discuss our findings and our barriers, and we developed action plans surrounding those. My project details did consist, so my important stakeholders are the VP of Quality, the CNO, IP Director, ICU Leadership, Education, the Vascular Team, and CNCs. With education, I did discuss the requirements and competencies that are needed to make sure that the nurses are aware of our initiative and what the expectations are. We implemented the usage of quite a few bundles, a CVC insertion bundle, where we monitor the intensivist on insertion and stopping the insertion if there's any fallouts with aseptic technique. We had a bundle for discontinuation, which we added with MDRs, identifying patients that didn't need or require central lines, and then maintenance bundles, making sure that we're changing the dressings with the appropriate kits and monitoring them and documenting them. I developed a discontinuation criteria in the ICU that was made aware to the intensivists and the nurses as well as leadership. I made an effective plan to use an MDR so everybody's on the same page. I reiterated the criteria for ordering blood cultures. We do have something called Ticket to Ride, and this is a list that the physicians or the nurses can check and have criteria for the patients to have in order for us to order blood cultures. And so with every blood culture, this ticket to ride needs to be done. If the patient did not meet criteria, then we would look at the patient's chart and see if it is actually warranted for a blood culture. And I developed a structured auditing process with the vascular team, the IP director, nursing leaders, and of course the frontline staff, which we leaned in a lot with the CNCs or the charge nurses to make sure that the auditing is being done daily and that the nursing leaders were reporting to administration weekly. Some of my project goals, of course, is to reduce the CLABSI rates in the ICU, reduce the usage of central lines in the ICU, increase compliance for using the CLABSI bundles in both the frontline staff as well as ICU intensivists and nursing leaders. I hope to get 100% competency completions of ICU nurses, and this means education, dressing changes, and just full awareness of the bundles. And then I do want to see or obtain accurate audit results. That way we can discuss it in real time and we can make a really good change. So with those goals, my project outcome was good. We were able to reduce the CLABSI rate since July 24. We have had 0 reportable CLABSIs, the lowest in the year. We've reduced our utilization since 2024, probably also the lowest in the year. We have had no new CMS reportable CLABSIs since we started this project. I did only have 40% compliance by the RNs of the awareness and the usage of the CLABSI bundles and the audits, but a lot of them aren't bought in yet with this project, and so it's just going to be a lot of education still. And we only still are seeing 50% compliance by the physicians on when to order blood cultures and the usage of the CVC insertion bundle set. But with more education, that should be better within the next couple of months, considering that we have had a decrease in the utilization, and we have had no CMS reportable CLABSIs. With the gap in nursing leadership for the ICU, right now they're only running with 1 director, no manager, and some free charges. So we do have some gaps in bandwidth for auditing. That's why we're leaning in on vascular team and the charge nurses to do a lot of the auditing, and then you have the ICU director as well as myself to fill in for the weekly audits and findings and developing action plans around it. So When the ICU is more full, more leaders are anticipated to be needed to do weekly audits for accuracy. My sustainability plan is to monitor the usage of ICU insertion and maintenance bundles, see accurate documentation, monitor accurate documentation, monitor the decrease of utilization, and having the nurses aware of when to de-escalate central lines. I would like to see over 80% competency in education and in training with central line dressing changes, audits, um, and utilizing the bundles. Decreasing CLABSIs and utilization rates, which is also our goal. Increased compliance with the surveillance and monitoring from leadership, and hopefully see an increase of leadership support, even if there is a gap in ICU leadership at the moment. If none of these or some of these are not sustainable, I will continue to hold leaders accountable for communicating the importance of the bundles to make sure that we have good patient outcomes. Some of the stakeholders' perception of my project has been, for the most part, very well. The administration department, which is a CNO, the VBQ, and the IP director, look over all hospital overall quality metrics and reimbursement. So they are happy that we have had 0 CMS reportable CLABSIs within the past couple months. The education department, a little bit overwhelmed with the amount of education and competencies that they have to go through with the nurses. We have over 140 staff members that need to be competent in the ICU. So I can see where they're coming from. ICU intensivist, they still a little bit skeptical for the ticket to ride and making sure that we have the central line audit, insertion audit tool, but they're getting there. ICU nursing leadership, again, there's a gap in there, but I am filling in with the ICU director to try to do these audits. The vascular access team has been really, really great in auditing the central lines, the dressing changes, the documentation. They are also available to assist if the nurses are busy. So that's they are good and willing. And the clinical nurse coordinators, just another thing on their plate is what they say. So, but all in all, if we show them the data that we don't have any CMS reportable CLABSIs, then we should be able to get everybody on board. My professional goals. My AONL competency goal, of course, is profession accountability. Accountability is very important to me because you have to hold everyone accountable in their role in order to be successful. And then building partnerships with other leaders. I think it's important to make sure that you lean on other leaders, other departments in order to be successful. In this project, I did lean a lot on administration. I leaned a lot on the materials management director with the dressing change kits and making sure we have all the supplies. I did lean in on the vascular team if the nurses weren't able to do dressing changes or document and things like that. They were available to step in. It's also important to lean in on other hospitals or other ICUs that went through the same thing and ask them about what their action plan was and what helped them. So that helped me also try to make action plans and things like that. I did get on a lot of division calls to see what other ICUs were doing. And of course, after this, I will still continue to be involved in the CLABSI prevention project and to make sure that we don't have any more reportable CMS CLABSIs. My key takeaways from this project and from this class is accountability. Like I said, it's very important to hold everybody accountable to their roles and their expectations. That way you can be successful. And of course, with this project, we want to make sure that there is leadership support. I found